Hello, good evening. This is Ganapathy here. Can you hear me?
Good morning.
We can hear you, Dr. Ganapathy. We can hear you.
Yes, please. Thank you. I think there's a little delay.
We were muted. Good evening.
Dr. Gopal, thank you for joining. I may have to request you to switch off your video because we want to save the bandwidth if you don't mind. Thank you, Gopal. We'll call you later. So nice of you to have joined.
There is enough bandwidth.
Okay.
And even if many people join and they are with their video on, won't be any difficulty. So,
Okay.
but whosoever likes to switch off the video, accept the speakers and the main moderators, that's fine.
Okay, I'll just switch on my slides just for half a minute to be sure that I'm getting it.
Yeah, please, and we'll do it one by one.
I request the others also to do it. You're able to see it?
Yes, we can see it, Dr. Ganapathy.
You're able to see it, right? Okay,
yeah,
thanks.
Dr. Sibal has also joined. He will conduct the further things, please.
Yeah, so I will switch off my slides.
Thank you very much. We can do, Dr. Pramod, we can also do for your slides also. You can share your screen. Yes.
You see it right?
Fine. Yeah, perfect.
Okay.
Dr. Ashish, would you like to check?
I've unmuted myself. Pleasure to meet you all. Are you able to hear me okay?
Yeah, I can hear you nicely. Can we just project your slides for half a minute?
Dr. Pramod, you need to exit. Dr. Pramod, you need to exit, please.
Yeah, I'm trying to move it
Unshare. Yeah.
So I'm sharing my slide here. Are you able to see my slides?
Yeah, we can see, Dr. Ashish, we can see.
Yeah,
thank you very much.
Fine.
And all of you are co-hosts, so you can mute yourself when it is not your turn. And then you can unmute yourself when you are speaking. Thank you very much. And we can see Ravi Kohli also. Ravi, can you speak? And we can check your audio.
Good evening and good morning from Pittsburgh, Pennsylvania. Ravi Kohli here. Thank you.
Yeah, we are waiting for Dr. Anjana.
She's here.
Dr. Sibal has already joined.
Good evening.
Dr. Anjana is also here. I saw her earlier.
Thank you, Ravi.
Yeah, hi, Dr. Sibal, how are you?
Very good. We've got a few minutes, so I think we're all set. Thank you very much, Dr. Tandon, for having done all the checks. So we'd just like to say hi to Anjana. Dr. Sangeeta Reddy is not going to be showing any slides, so we are good. And she'll come live when it's her turn. And so there are no slides there, so we don't need to check anything.
Oh, we also need to welcome Sir Dr. Thais Mano. She is also going to be in the next session. She's the chief of space.
Thank you so much for finding time for us. And thank you, Dr. Ganapathy, for your passion and for getting all of us on board and excited as you always do. It's amazing the passion, the commitment you have for telehealth, and it's paid such dividends.
Thank you, Anupam. Since you have 2 minutes, can I request Dr. Gopal to switch on your video? Professor Gopal is a professor of computer science at Anna University. He's a very well-known professor at the Anna University and is involved in very many projects. We know each other for several decades. Thank you, Gopal.
Good evening to all of you, Professor Ganapathy. Thank you for so many nice words. And congratulations to you and your team on this occasion. Thank you.
Thanks. Anjana, can we just do a check audio and just request you to please move the camera so that we can actually see you. As of now, we can just see bits of it's so much better. Thank you. Just unmute yourself.
Unmute. And also, if you can change your name, that will be nice.
Yeah, Anjana, you can change your name from Moda to Anjana. Unmute yourself, please.
Okay, that's my, this is my office computer.
Perfect. Now we can see you nice and clear. Thank you so much. So we shall go live in about 3.5 minutes.
Okay. Dr. Siebel,
While we
I'll
are,
talk to you later.
while we are waiting, I just want to acknowledge Dr. Tandon, Dr. Sibyl, and others, and Dr. Kohli for having me. And this will be such a great group to actually even have a detailed discussion afterwards, how we can collaborate, in the US in that regard.
Absolutely.
Dr. Siebel, I'll be having my Global Health Summit in Delhi.
Oh, you're having it in Delhi? How nice. I thought you were going to Calcutta.
No, I'm going to do it in Delhi, and I'm coming to India on the 19th of April. So maybe I can
Great. No, we
come
must
and meet up with you.
We
I'll
must
meet up and we'll talk.
We must
We'll
meet up
talk.
and plan.
Absolutely.
And I'm so glad you're planning so much ahead because Ravi's got
Absolutely.
his dates already fixed. So you'll be
Right.
looking at January
24. 24. Yes. I actually have my dates also. So
Okay.
it'll be from the 2nd of January to the 5th. So
Fantastic.
Great. Maybe we should do it on Republic Day, no?
yeah, sure. Why not?
You guys have to look at your holidays because you like to combine them with your Christmas.
Right.
vacations.
Absolutely. Absolutely.
But keep in mind, there are a lot of restrictions on travel within Delhi during the Republic Day. I mean, closer to the Republic Day, that is 24, 25th, 26th.
Right. No, but we are doing it 2nd, 3rd, 4th January. So
Okay, that's good.
In case there is any bandwidth cap, I'm also sharing my slides in the link in the chat.
okay.
I guess I'd request everyone to please go on mute so that we don't have any disturbance and unmute as you start speaking. Requesting everyone to please go on mute. Namaste. It's 5:30 a.m. in LA and Vancouver. It's 8:30 a.m. in New York. Good morning to all our colleagues in the United States and Canada. It's 1:30 p.m. in London, 2:30 p.m. in Europe. Good afternoon to our friends in Europe. It's 7 p.m. in India, 9:30 p.m. in Singapore. So good evening to all our colleagues in Asia. And at 12:30 a.m., it's well past bedtime for our colleagues in Australia. Namaste and warm welcome to all our colleagues from across the world. I'm Anupam Sibal. I am the current president of GAPIO, and I work as a pediatric gastroenterologist and the group medical director of the Apollo Hospitals Group. For those who are joining for the first time, GAPIO, which is the Global Association of Physicians of Indian Origin, aims to bring 1.4 million physicians of Indian origin across the globe on one common platform, and we now have members from 53 countries. GAPIO is delighted to be a part of this exciting program as we celebrate the 22nd anniversary of the world's first VSAT-enabled village hospital at Aragonda in Andhra Pradesh in India. On March 24th, 2000, the Aragonda facility was commissioned by Mr. Bill Clinton, the 42nd president of the United States, when he visited India. ISRO has acknowledged that it was the first 2 years' work at Aragonda, which made ISRO install almost 400 plus VSATs in hospitals across India. The Aragonda experience led to widespread adoption of telehealth by many institutions throughout the country. With experience, presentations and publications were produced, which resulted in greater awareness about telemedicine. Today, we have a distinguished group of experts from across the globe to discuss telehealth. Let me invite my dear friend, Dr. Ravi Kohli, President-elect of the American Association of Physicians of Indian Origin, API, to moderate this session, along with Dr. Anjana, who is the Vice President of API. Ravi is a US board-certified psychiatrist and is the Psychiatric Medical Director at Southwestern Pennsylvania Human Services. He's a recipient of several awards and honors. Over to you, Ravi.
Good evening. I'm Dr. Ravi Kohli. I'm a psychiatrist in Pittsburgh for the past 30 years. And I also welcome our 42nd president of API, Dr. Anjana Samadar here, the vice president. And it's coincidental, the 42nd president of USA inaugurated the telesession. And we have our 42nd president as well here. And Aragonda in Chittoor district is famous for its Ardhagiri Anjaneya Swami temple, as well as the first VSAT satellite connected telehealth clinic. It's my distinct honor and pleasure to be here with you. And I also commend Gapio for the distinct job they have been doing over the past 2 years under the leadership of Dr. Sibyl and of course, my good friend, Dr. Tandon, the backbone of many events. And without further ado, I want to get on with the program. And it's my honor and pleasure again to introduce Dr. Professor Ganapathy, Director of Apollo Medicine. He's a pioneer in this field, and he's probably Mr. Telehealth of India, I would say. And let me give you a formal introduction of his various credentials. Professor Ganapathy is the Director of Apollo Telehealth Services and Apollo Telemedicine Networking Foundation. Professor Ganapathy is the past president of Neurological Society of India, Telemedicine Society of India, and Indian Society of Stereotactic and Functional Neurosurgery. Professor Ganapathy is an honorary distinguished professor of Dr. MGR Medical University in Tamil Nadu, and emeritus professor of National Academy of Medical Sciences of India. Professor Ganapathy is a former adjunct professor of IIT Madras and Anna University of Madras. And also Dr. Ganapathy is a member of editorial board of national and international journals in telemedicine neurosurgery. Dr. Ganapathy has written multiple papers, at least 578 papers, chaired more than 200 sessions in national conferences, and made 192 presentations in international conferences, published over 310 scientific papers in index journals, medical as well as non-medical magazines, and newspapers, as well as contributed over 21 medical chapters in medical texts. The floor is yours, Dr. Ganapathy. Please go ahead, sir.
Thank you, Dr. Ravi, for that introduction. I wish my parents had been here. They almost would have believed it. It is going to be impossible in 900 seconds to tell you what my team has done in the last 22 years. Nevertheless, I shall try. You're able to see the slides, please? Are you able to see the slides?
Yes, we
sir,
are.
we can see your slide.
Yeah, because once I gave a talk without anybody seeing the slide. Okay. It all started actually in 1998 when I had the audacity to write to the Association of Rural Surgeons of India 24 years ago and suggest to them that technology-enabled healthcare is doable in suburban and rural India. Thanks to the fantastic encouragement given by Padma Vibhushan Pratap Sri Reddy, the founder chairman of the Apollo Group, he was the only one who realized that this would one day be a reality. Honestly, none of us foresaw that a strand of RNA would act as the global CTO, Chief Transformation Officer, and in 2 years, what we could not do in the preceding 20 years. The first 5 to 7 years was exciting purely because Apollo Hospitals was unique. We had presidents from African countries, from European countries. Here you see photographs of the president of Nigeria, Prime Minister of Mauritius, Prime Minister of Macedonia, President of Uganda.
Sorry, Dr. Ganapathy, your slides are not moving. You have to go to slideshow and move your slide.
No, I know, I was moving the slide. Now is it moving?
No, it's not. Go to slideshow.
Now?
No, it's start. Go
Can
to
you go to the
slideshow.
tab slideshow and start from the beginning? And then you can click
start.
enter for each slide to come forward.
It is it's moving on my screen.
No,
We can
just
see
go
the
to slideshow. Go to the
window.
last icon, press it, please.
This go to the 1, 2, 3, 4, 6 tab.
So under new share, I've clicked on new share.
That's fine. Now on your slide deck, you're at the home button, but go to the slideshow button
Okay.
and then hit that. Okay, perfect. Yeah.
Is it seen now?
Yeah.
Yeah, now we can see all the dignitaries.
Probably you have gone
Okay.
forward, but if you
Okay,
want to
sorry
go back,
about that. Okay, so this slide you see the Prime Minister of Mauritius, Prime Minister of Macedonia, and so on. Is the next slide seen?
yeah.
Yeah, okay, this is really a unique slide. If you see the date stamp, 31st of October 2001. I'm not aware of any place in the planet where tele-echocardiography was done. Unfortunately, this video, I don't think you'll be able to see it, but you can see our pediatric cardiologist who interpreted as many as 200 pediatric echocardiograms over a 2-year period and handheld, telementored a technician in the village of Aragonda. Unfortunately, we were so busy with regular clinical work, we were unable to publish this as such. The next slide you see, today it looks very silly, but believe me, in 2002, in fact, the date says March 26, 2002, it was exactly on this day that I represented India, Apollo Hospitals represented, and spoke on an intercontinental teleconference. Bill Gates was the previous speaker, but of course he spoke and went without listening to me. And on the bottom left, you can see how the whole concept of telemedicine was so novel in 2010, 2015. We had students from Harvard Business School, from Yale School of Management, University of Michigan, Georgia State University, Wharton, London School of Economics, and so on. I always felt that engineering colleges would be the best place to start because engineering colleges already had internet connection, departments of computer technology, and so on. And so we concentrated on engineering colleges and succeeded even 20 years ago, a few of the colleges to start telemedicine units in their premises. In 2007, we held the first international telemedicine conference in India, something truly unique at that time. 350 delegates from India and 50 from overseas. The picture on the left looks absolutely silly today. On my smartphone, I can get people from 5 different continents, multi-point video conferencing on my smartphone with 4G connectivity. But believe me, in 2001, the Consul General of the United States of America thought this was an event important enough. So did the Consul General from Japan to visit Apollo hospitals to formally inaugurate the first neurosurgical teleconference with universities in the United States and Japan. This was how it all started. I strongly believe that patient empowerment is the way to go, knowledge empowerment, and most health conditions can probably be prevented if only we promote health literacy. Promoting health literacy the E-way, that was our motto. Professor M.S. Swaminathan, a world-renowned agricultural scientist, he runs the M.S. Swaminathan Foundation, and more than 20 villages, we entered into an agreement with him. And this was very exciting for us. For about 6 years, twice a month, we would hold multi-point video conferencing educational programs in the local language. About 300 to 400 villages would attend this, and more than 40,000 villagers have benefited with this knowledge empowerment over a 5-year period. The Pan-African E-Network started by the Ministry of External Affairs, Government of India. Unfortunately, due to various reasons, including political, it had to be disbanded after 8 years. But for 8 years, from my department in Chennai, we were connected to 42 countries in Africa, constituting the entire Pan-African network. And you can see on the top right-hand side, the body language speaks for itself, how attentive these people were listening to lectures. Again, Apollo Hospitals Chennai had the unique distinction of contributing almost 50% of all the CME programs and more than 50% of all the patients seen at that time. Healthcare in the most treacherous area on planet Earth. This is in the Himalayas at a height of 14,800 feet, temperature minus 25 degrees centigrade. The government of Himachal Pradesh were persuaded to give us a chance to do what was Asia's first public-private partnership. And we took a challenge from the chief secretary. I so vividly remember making the presentation to him. And on the top right is a photograph showing how patients were taken to the nearest hospital, which is 250 kilometers away. Today, 5 years later, we have set a benchmark, and today we have many more public-private partnerships. I am not a CEO by training. I do not know anything about profit and loss, business management. I'm more an academician, a teacher, and a researcher. And with this background, we capitalized, exploited this, so to say. And here you can see several books, several publications, a healthcare information technology and monograph was brought out, and dozens of papers, many of which today have been used as standards. In fact, a Google Scholar review said that articles published from ATNF alone have been downloaded more than 45,000 times and cited in Google Scholar more than 200 times. One particular paper, Distribution of Neurologists and Neurosurgeons in India and its relevance to the adoption of telemedicine, has been downloaded 17,875 times and now is used as a standard in the deployment of neurosurgeons in most countries in the world. These are all details of the webinars which we have contributed to, podcasts, TV interviews, etc. The first 15 years was spent in evangelization and creating awareness. We tried to follow in the footsteps of Dr. Pratap Reddy. I think the greatest achievement of Apollo hospitals is not the 72 Apollo hospitals, but rather proving to India that a for-profit dividend-declaring corporate hospital is doable in a so-called third world environment. Similarly, I would like to think that we set the way, and today we have at least 30 to 40 telemedicine institutions in India, which have very good telemedicine departments. The government of India has launched the e-Sanjeevani network, and it is most gratifying that no less a person than the Prime Minister mentions telehealth every time he addresses the nation. So the public-private partnership, I'm not going to bore you with all these numbers. Numbers by themselves don't mean anything. What is equally important is that the huge numbers we are dealing with, we do not dilute quality. And I think that is the most important lesson we have learned. Even for the 13 million teleconsultations we have given so far in a public-private mode, the same quality is maintained throughout. Tele-radiology services, tele-emergency services. We run the world's only 24/7 tele-emergency services at a 15,000 feet height. CSR, corporate social responsibility. The University of Pittsburgh has entrusted it with a major project in a tribal village about 350 kilometers away from Ahmedabad in Gujarat. They give us a grant of about $150,000 a year. And for the last 2.5 years, we have been doing this very successfully. Unfortunately, because of the COVID, a very major partner of ours, we had to stop the CSR activity. But when it was on, we did an NCD screening of 1.5 million persons, which by itself may not be very unique. But what was unique was we provided teleconsultations in a camp mode. We enabled the people visiting a camp for screening to instantaneously contact diabetic counselors, psychological counselors, doctors, etc. And we provide them with almost a one-stop treatment for diabetes, obesity, and so on. But because of time constraints, I'm not going into the details, excepting that we do audio consultations, video consultations, etc. We now do about 23,000 e-transactions every single working day. The journey that began 20 years ago, today we have 110 teleclinics in a franchisee mode, more than 800 healthcare centers in a public-private partnership mode in many states throughout the country. We believe that training alone is not enough. We concentrate on unlearning, untraining, if I want to use that word, retraining. We are always up to date, and we believe in being future ready all the time. So this you can see, POCT, point of care diagnostics. We have that, and today we literally provide laboratory services in the remotest parts. We always we do not want to be behind the times. We are future ready. Just 2 weeks ago, we completed an excellent POC, proof of concept validation, with the Niti Aayog, the Government of India's Planning Commission, World Economic Forum, and the Government of Telangana. And over a period of 4 months, with several hundred drone flights, we have now fine-tuned the whole thing, and now we are ready to make it absolutely escalate this and do it in a much bigger way. So drones is going to become an integral part. Couple of years ago, the chairman said, I quote, "We need to double our doctors, triple our nurses, quadruple our paramedics." Ladies and gentlemen, this is just not going to happen, not in the lifetime of my great-great-grandchildren. Last year, Dr. Reddy publicly announced treatment outside hospitals is going to be the future of healthcare. I presume that the days of huge multi-speciality hospitals, mega hospitals, 1,000 beds, 2,000 beds are going to be a thing of the past. I foresee that in the years to come, and I'm not talking of the distant future, I'm talking of very soon, hospitals will only have ICUs, trauma units, and procedure-related events, wards only for procedures. The hospital will be where the patient is. A doctor in your pocket, a laboratory in your pocket, a hospital in your pocket, an ICU in your home. As retail becomes stronger, what will move out to the hospital? Everything will move out to the hospital, according to McKinsey. This is a report done by McKinsey. It is not what I am saying. Vaccines, physical examinations, outpatient departments, diagnostic procedures, date procedures, laboratory procedures, and so on. Smart health kiosk. Again, a trial is now going on. Apollo is doing this with many corporates, and I'm sure that in the next couple of years, this will become our way of life. As I mentioned earlier, we are obsessed with quality control, thanks to what we inherited from the Apollo Hospital Group. And we are very delighted that in December, we acquired the world's first ISO 13131 certification for telehealth services. This ensures, because re-audit will be done, this ensures that we always keep up to the mark. What you see here is our office in Hyderabad, one of the largest medical call response centers in this part of the world. A couple of years ago, when I spent a few hours in a virtual reality environment, I never in my wildest dreams dreamt that Apollo hospitals, Chennai, Delhi, and other places would have simulation laboratories state of the art. And I'm sure that very soon we will have people coming from all over the world to visit our simulation laboratories. The metaverse, no less a person than Zuckerberg, renamed Facebook as Meta, and the metaverse is what is going to be the future. The future of telemedicine, I believe that telemedicine is no longer going to be considered as a separate standalone entity. It will only be a small component of what we like to call digital health. And I'm happy that the next two speakers after Dr. Pramod will be talking on digital health. And personally, I don't like the word telemedicine. Medicine implies a one-to-one relationship between a doctor and a patient. Today, we are talking of healthcare. We are not talking of diagnosis and treatment. We are talking of keeping all of us healthy the e-way. Promoting wellness, I think, is what can be done remotely. I would like to conclude with this photograph, which I got just 3-4 weeks ago. India, ladies and gentlemen, is a paradox. On the one hand, our global developmental index is in triple figures. We are still referred to as down south. But where else in the world will you see 10 below poverty level farm laborers chartered a bullock cart for $2.50 for a round trip, traveling 50 kilometers from the remotest part to reach an Apollo telemedicine center, and for 0 rupees, free of cost, in 25 minutes, all these people were able to connect to the same dermatologists, the same family physicians who treat the urban elite in Hyderabad, Chennai, Delhi, Mumbai, and so on. Where in the world will you see a globally renowned chain of hospitals using technology to reach the remotest centers? This is the real India. And I am sure that in my lifetime, these bullock carts are going to be replaced by electric vehicles, electric three-wheelers, electric two-wheelers. And I'm absolutely sure that India will no longer be referred to as a developing country. In conclusion, I would like to mention that if Moses were to come down to the earth today and once again tell us the 10 commandments, he would preface every single commandment with the words, "Thou shalt digitally transform." I think we all know this. And again, I was shocked. I was not surprised. I was shocked when in the budget, I heard the finance minister talking about taxing digital assets. The Reserve Bank of India talking about cryptocurrency. I mean, who says India is backward? I really think we are as forward as most of the countries in the world. You can ignore reality, but you cannot ignore the consequences of ignoring reality. We need to be future ready. Many of us are afraid of the future. We cling desperately to the present, not realizing that we have already become the past. I dream of the day in my lifetime when there will be no need for a telemedicine society of India. After all, there is no stethoscope society of India. The telemedicine should be an integral part in the armamentarium of everybody, whether it is nuclear medicine, space medicine, pediatrics, fetal medicine, whatever it is. It should just be a tool, and people like us who try to promote this, we should be out of a job, and I would be the happiest person if I am out of a job. Thank you once again. Thank you, Dr. Anupam. Thank you, Dr. Tandon, for the superb work you have done in putting all this together. I look forward to the other speakers.
Thank you, Dr. Ganapathy, for that inspirational talk. You were there from the beginning. And like you said, knowledge empowerment, taking the care to the footsteps and the doorsteps of the patient is the key to wellness care. And also technology has equalized the playing field and brought the care to the remote areas. So India has been able to leapfrog the legacy technologies and embrace the digital technologies quickly and really reap the benefits in delivering the care. And without further ado, let me introduce the next speaker, Dr. Pramod Gaur. He's an adjunct professor at Pace University, New York, USA, and is the co-chair of Technology Collaborative of Westchester County Livable Communities Program. Dr. Gaur received his doctoral degree from University of Kansas and his postdoctoral training at the University of Wisconsin in Madison and University of Maryland in Baltimore, USA. Activities of Dr. Gaur include, in the past 20 years, as the advocate for digital health industry, presenting demonstration to the US Presidential Advisor, US Congress, the White House Conference on Aging, and international delegates at the United Nations. And Professor Gaur was inducted into American Telemedicine Association and considered as the preeminent telehealth subject matter expert. Dr. Gaur served companies. So the floor and the screen is yours, Dr. Gaur.
Thank you very much, Dr. Ravi. It's my pleasure to be part of this distinguished panel. Dr. Ganapathy, thank you very much. We have been working together for almost 2 decades, and it's a privilege to see this recognition and remembering 22 years since the started in India. I've been asked to speak about insurance and telehealth, and I will try to give you the update and also end with the edge, picking up what Dr. Ganapathy said, that telehealth, telemedicine should not be just a standalone activities. It should be incorporated as how overall digital health and the care is delivered. So before I get the specific part of reimbursement, very briefly, this is the chart that I have used for many years when I was at United Healthcare. Anytime we are looking,
Dr.
Can
Gaur,
you hear?
We can't see your screen.
You cannot, okay. Let's see.
Screen share, please.
Yeah. Are you able to see now?
We're good now.
Okay, so let me. So this is the slide that I'm showing you briefly. This is how any new initiative, new program we look at, you have to look at all the key components. And what you see in the center are the four key constituents: the patient, their caregivers, family members. On the upper right, you have the providers, the hospitals, clinics, doctors, nurse, case managers. And in the bottom, you have on the left, the policy regulators, a federal government, a state government, medical board. They all creating policies that impact the telehealth. And then the bottom right is the payers, not only the private insurance companies, but also federal and the state government. And also in the United States, you have a large percent of employer-sponsored healthcare. Outside, I put it, I'm not going to go in detail, are some of the industries that are impacting these four key stakeholders. So my talk is to focus on the bottom right, the payer aspect of insurance and reimbursement. So how is the US population is insured? And so what 2019 data suggests that you have about 50% of the population is getting insurance through the large employers. They are self-insured. They contract with the health insurance companies to administer the insurance coverage, but they take the risk. Then you have a small percentage, about 6% of US population are buying directly through the insurance companies. And then you have about 35% of the population is insured through the federal government, through Medicare program or Department of Defense and Veterans Affairs. The state government have Medicaid and dual eligible. And then you have about 9% of, sadly, the US population is still uninsured. Some of them are able to pay, others are being absorbed by the local government. So this is the distribution. About a third of the population is covered by the government, 2/3 by the private sector. So what kind of reimbursement for is it? Number one is still is a traditional fee for service. When someone conducts a consultation, they bill for it, although it's decreasing, but it's still pretty substantial, is what we call traditional fee for service. What is it changing is the second one, what we call capitated or negotiated rate. Here you have, I just picked a 3 or 4 example. ACO stands for Accountable Care Organization. In this situation, multiple stakeholder providers are joined together and are given a pool of funds to take care of the individual. Similarly, you have PCMH, patient-centered medical home. Here, all the activities to the patient are coordinated and paid together rather than individual services. Bundle payment, where they are covering multiple activities that were billed separately, but they are now bundled and fixed rate. And episode of care payment is similarly when they have a heart surgery or procedure or cancer procedure, there's a flat rate. So that's the trend has been moving into this kind of reimbursement rather than traditional fee for service. And we will discuss it in a minute. That sets up very nicely for broadly using the technology rather than just episode traditional fee for service. The other areas where the reimbursement is done by employer and other prevention incentives, and also there are some tax dollar healthcare savings account and flexible account. People are paying from this, and there's still self-pay. So what kind of services are reimbursed for telehealth? This is a small group of activities that United Healthcare and other insurance companies are providing. So you have chiropractic therapy, electronic visit, home health and hospice services, physical health, occupational health, remote patient monitoring, telehealth, state provision, virtual check-in. So as you can see, it's already more than just say video teleconsultation or remote services are being reimbursed. And here the statistic, obviously, the COVID-19 pandemic came. A couple of statistics here I just want to show you. From March 2019 to March 2020, the upper part of the slide is showing you had 28,255,180 unique telemedicine users. These are the the population. That's 53% of Medicare population, traditional fee-for-service, traditional Medicare. So it went from 910,000 to 28 million. And then in the bottom, the statistics I'm showing you 52.7 million visits. So these are visits. The other top number were the users. That's the 5% of Medicare fee-for-service visits, not the people. And that's a 63% increase from in a year. So as you can see, there was a huge increase from due to pandemic, and I will cover in a minute as to where we are going from this. But just to complete that, this is not only from the federal government, but also that's from United Healthcare. All the different procedures were done. They're following the CMS CPT code guidelines, and as well as covering this is for remote patient monitoring for Medicare patient, as well as Medicaid or privately insurance company patients. So what is then happening now? This is where we, as I mentioned earlier, as the payment models are changing, what I'm showing you in this slide, going back to the earlier one, is that two of the key stakeholders are now partnering. You got provider and payer are forming partnerships. Sometimes they are offering, both of them offering both services. The new term is called pay-wider, and so it's a combination of provider and payer. And this partnership has really potential to change dramatically how the care is provided, and hopefully it will be a lot more affordable and better satisfaction. So why is this happening? This is set forward with the through the Affordable Care Act, that were these ACO, patient center home, all these pilots were done for the last 5-6 years. And now we have sufficient data that suggests that rather than fee-for-service, the buzzword is a value-based payment done where the reimbursement or payment is based on the outcome rather than just fee-for-service. An example for these, they were already in place in the US West Coast. There's a Kaiser Permanente, is a large organization. Beside California, they have all the few other states. They have facilities, Mayo Clinic, another one, Cleveland Clinic. These are the three big ones that most of people know, but other organizations are also starting to form this what we call sometimes self-insured, UPMC, University of Pittsburgh Medical Center, and of course, one of the largest one is the Veterans Affairs, the USA VA. These are all organizations where they have both the payment as well as the provider services combined. And so this is the direction I think is moving. And this is my last slide, where the demand has increased tremendously on a temporary basis during the COVID-19. And so even countries where there is a rather than private insurance company, but is covered by the government funding, like NHS in UK and other European countries. That was done during the pandemic. Hopefully we will be coming, easing into the pandemic sometime in the next year. So now the focus of American Telemedicine Association and others is what should be the continuation. There should not be a cliff when the emergency is lifted, then all these reimbursements are gone and we go back to the old fashion. Luckily, we have been able to, as a organization, association, able to influence the policymaker. And recently, just within the last 30 days, a new bill was passed where it is now part of the law that once the public emergency ends, at least another 151 days, 5 months, the reimbursement will continue as it is. Furthermore, the Congress has requested that by mid next year, there should be a specific data presented with the outcomes of the incorporating telehealth and telemedicine, so that they can look at and try to make it permanent. Worldwide, other countries, including in India, Insurance Regulatory Development Authority had also reacted with the COVID pandemic and allow private health insurance for individuals if they can be reimbursed for virtual care. So in conclusion, the way it is moving now, as Dr. Ganapathy also had mentioned, that what is happening is digital incorporating into the way a care is delivered. A lot of time the buzzword we're using, digital front door, people would be able to use the digital technologies to interact first. In fact, starting this year, there's some private insurance policies where they say digital first. It's a lower premium if you sign up of that insurance program, where at first you use digital and virtual primary care to decide, do you need to go to an office and other pieces. So as I look it forward, I'm just like Dr. Ganapathy say, in a few years, it will not be a standalone, just a telehealth, telemedicine consultation services, but the technology will be incorporated. Every aspect is checking symptoms to scheduling, and the provider will choose along with patient whether it should be a virtual or in person or combination. We use word hybrid care. So with that, I will stop here. Thank you so much for the opportunity.
And that was a great talk, Dr. Gaur, from the global perspective about insurance and telehealth. And one good thing that came out of the pandemic is the telemedicine adoption and adaptation by the patients and providers, and as well as the policymakers. Now the purse strings are in the hands of the payers, right? They hold the key to further expansion and further implementation of it. And probably you're in that field, you can probably advocate for that more. And without much further ado, let me introduce my good friend, Dr. Anjana Samadar, who is a practicing gastroenterologist in Columbus, Ohio. She is the vice president of AAPI, and she'll be the president-elect in a few months. And afterwards, she'll be following me as the president. She is the medical director of Mid-Ohio Surgery Center and also a Mid-Ohio Digestive Disease Associates. She is assistant professor at Ohio State University in the Department of Gastroenterology. As I mentioned, she's the vice president of AAPI. Thank you. Anjana, floor is yours.
Thank you, Ravi. I've been enjoying the great talks by Dr. Ganapathy and Dr. Gore. And right now I am honored to introduce another great speaker, Dr. Treja. And he will be speaking about digital health and the start of an exponentially better care. Well, Dr. Ashish Atreja is a well-known physician who oversees UC Davis Health, Sacramento, California, USA, expansion of its digital relationships with patients and with other hospitals, bridging the gap between IT, academia, research, and innovation as Digital Davis becomes a global hub for digital health. Prior to his UC Davis health appointment, Dr. Treja served as the Chief Innovation Officer for the Department of Medicine at Mount Sinai Hospital, where he established one of the first innovation hubs within an academic medical center to build and test disruptive digital health technologies. And he also launched NODE Health, an association of digital medicine. Dr. Atreja is graduate from All India Institute, New Delhi. He's adjunct professor at AIIMS Rishikesh and on National Advisory Board of Swastha India. Dr. Atreja is credited with coining the term evidence-based digital medicine and is often referred to as the APP doctor for his work in pioneering digital therapeutics and prescribing mobile health apps for patients. Dr. Atreja, I would love to invite you, and I'm honored to invite you to give us a wonderful talk, and I'm sure you'll do it. Thank you, Dr.
Thank you,
Atreja.
Dr. Anjana. Thank you. It's a pleasure to be here. I also want to extend my thanks to Dr. Ganapathy, Dr. Sybil, Dr. Tandon, Dr. Kohli for having me here. And congratulations for this wonderful event and celebration. I will build on the prior discussions and the presentations by Dr. Ganapathy, as well as by Dr. Kaur, to really see how we are moving beyond virtual care as a base to actually really looking at digital health and what we call as one-to-many care as a mainstream technology for the future. I'm hoping you're able to see my slides.
Yeah.
If that's correct, then I'll proceed. I know I was already introduced, and I also want to mention I'm a gastroenterologist, and I already have seen 2 gastroenterologists out here. So I'll do some dirty jokes from gastroenterology and engage them with the digital health in that regard. But one of the things I wanted to mention about UC system is we are a public university. We're funded by state. So we are very mission driven. 50% of all NIH money that comes to California comes to University of California schools. And we have not only the 5 medical schools, but we also have around 20 other schools that includes UC Berkeley Computer Science, Biomedical Engineering, UCLA, UCSF. So together as one legal entity, our goal is to really build and thrive latest technologies. And we are granted more US patents than any other university in the world. So with this rich ecosystem, we are trying to reshape how healthcare delivery in the future can look like. And I know it was just presented, Dr. Gore as well, how much telemedicine had been adopted in US. And COVID was a big catalyst in using of telemedicine. And how I see telemedicine is most of the healthcare delivery before telemedicine was locked in space and time, right? There's a science of medicine where 95% of patients' blood pressure can be controlled with current medicine. And there's actual delivery of care where less than 50% of patients are controlled for blood pressure. And the delivery of care is lagging behind the science because of our limitation of space and time. What I mean by that is we had to be physically together with a physician to get care before. Now we have unlocked the space dimension in virtual care. And at UC Davis Health in 1992, Governor Schwarzenegger launched the Center for Health and Technology. So we trained telemedicine since 1992. But telemedicine, what it cannot do is it still requires the physician time. How can we move what Dr. Ganapathy mentioned to care at home without us getting 4 times, 10 times more clinicians and paramedics? And the answer for that is digital medicine and digital health. That can truly unlock the potential for exponential care at home, bridge the gap between the science and what we see as delivery of care. And I'll give one example of that. 92% of patients in US, and I would probably admit 75% in India, if not more, have, or 60% have access to a smartphone. Each smartphone has 1,000 times more processing power than all the NASA supercomputers combined, which led the man on the moon. If we unlock the power of that processing through sensors, through linked variables, through AI machine learning, through virtual reality, Alexa-like voice commands, and we embed our principles within that, what we call as digital care principles, we can suddenly deliver one-to-many care, where instead of me speaking to every single patient and telling how to do a colonoscopy, how to prepare for a colonoscopy, patients can automatically be guided on that. And we can really create a very super efficient system, which is replicable across the world. Because once we embed these principles into an app, you can actually distribute that app. You cannot ship a physician globally, but you can distribute the best practices of that physician, of that hospital, packaged in an app globally. And I'll give a few examples, and I know Dr. Gaur mentioned about digital front door. So this is a great example coming from Australia, where one of the major gaps is you can stent a patient, but you cannot change their behavioral outcome. Many patients do not stop smoking or do not take their blood pressure medicine. But if you create a text messaging program, which these people do, you actually can have a 40% reduction in smoking. You can have a reduction in blood pressure and the cholesterol levels, where the text messaging bot is engaging with the patient and guiding them how to do it, right? But now we can take this Text Me program and actually deliver it globally at a fraction of a cost, because this is now replicable and reproducible as an asset. The other example on digital monitoring is this app for what we call as digital therapeutics for diabetes control, right? The biggest gap in diabetes is not the medicines we have. It's the health literacy, which Dr. Ganapathy mentioned, right? How can we, and closing the gap, if we tell a patient to just track their sugars and come back after 2 months, many people forget how to document it. Many people forget to bring the digital log. So it takes like a year to control the sugar, just because we do not know what's the status of the patient is. But if we can have a Bluetooth connected app, which will take real-time readings with a glucometer and feed into a cloud AI platform and tell the patient what to do real time, we can actually have the same improvement with an app as with introducing a new medicine. And this is now getting FDA approved in US. There's a whole science of digital therapeutics that are formed. So once it is formed, we can distribute it nationally and globally, right, to any health system in the world. Now, with the challenge that is coming in digital health is not the solution, is that there are too many solutions coming up. So there's a problem of plenty, and who can then find which is the best solution, which is not the best solution. At this point, there are more than 4,000 digital health companies across the world, right? And we are facing the other challenge and how to actually take that and really deliver to our health systems the best technologies. So we have created here a Digital Davis platform. That's our vision, where everything is on a cloud-based platform. What you see in yellow is the current EMR and the virtual care, but we need to go beyond to create a digital front door across many service lines. And we need to build in automation for all procedures and surgeries. We need to leapfrog on digital monitoring to support care at home, because the future of healthcare is where 99.9% patients spend their time, and that is at their home. Can we bring the same experience at the home? And then can we create a sandbox to test new technologies? So we, in my past role at Mount Sinai, we created the first digital health formulary in the world, where very much like doctors can prescribe medicine, doctors can now prescribe apps and digital care plans and virtual care and wearable devices right from the electronic medical record, right? And this is a screenshot of Epic, which is 70% of academic medical centers in US use it. But this is independent cloud-based system which can be embedded into any EMR in India, US, Australia, UK, or anywhere in the world. And we can create a formulary which is approved by that health system. And the physicians or nurses or paramedics can prescribe app to supplement the care and the care guidance and health literacy, which patients need at every single point of their care. Before we had this formulary, when we tell a person to get an app, we had only 6% adoption rate. And the reason was the patients were getting lost with the 450,000 apps in the market. They were sometimes misspelling the app. And then they have to do iTunes signer and password. So we were able to convert that into an opportunity where the app was prescribed by a patient, directly lands onto the patient's phone through a text message. And we all had all the credential on the backside, so patient did not have to remember the iTunes password. We were able to create from 6% activation to 92% activation and education. And talking about my favorite GI world, one of the biggest challenges we face in GI is how to prep patients for colonoscopy, which is $3,000 for a procedure, right? We tell a patient, hey, do these things, but there are at least 15 steps a patient has to do. It's a big health literacy issue. If patients do not do that in the right manner, we have 1 in 4 colonoscopies having a poor bowel prep. Can you imagine a procedure or a surgery which is $3,000, but 1 in 4 of them is actually a failure because that has to be repeated within 1 year? That's $51 billion cost to the US healthcare market. So we automated with partnership with the American Gastroenterology Association, all the pathways what patient has to do. And as soon as an appointment is made, the patient gets a text message. They get an appointment right on their iPhone and Android. They get driving direction and parking direction. They get a chance to watch the video, and they get 10 days before, 5 days before, 2 days, what exactly to do and how to do. And we were able to show 30% reduction in appointment, no-shows, and 50% improvement in bowel prep, and 50% reduction in poor procedures, right? So our journey then continued. We were able to show connecting with connected devices, that wearable devices, 50% readmission reduction when we send a patient to home. We were able to show a half-a-day reduction in length of stay and 20% more patients going to home after a surgery versus going to nursing home. Before they were so much well prepared how to do and do things. Now we are enabling the same kind of initiative for research, what we call as a decentralized trials. And in the middle of pandemic in New York City, we were able to reach to 1 million patients within 8 weeks and had 55,000 people automatically digital monitoring, which would have required around 100 nurses to do over 6 months. We were able to do automatically at less than $1 a patient for 55,000 people, right? So this automation AI is now converging with digital health to really extend what all framework has been happening in virtual care to create a new model of one-to-one managed care. So a lot of these pathways are triggered automatically now based on the AI algorithms. So across UC, we have now combined all the data, what we call as an OMOP data model with structured data, along with natural language processing, and working with AWS to create lakehouse concept. So we can pull data from anywhere, even data that has not been for us. For example, patients' social media data, social determinants of health data, how they are doing in their locality, remote monitoring data from devices, Internet of Things data from smart fridges. So we can actually say this patient needs this and automatically trigger this care pathway. But there's some things we as health system alone cannot do. For example, we need to do an equal work as we expand this technology, that we do not create a bigger gap in digital divide. We need to create a digital bridge, right? We need to work with governments. We need to work with nonprofit world to really enhance digital literacy for nearly everyone. And for that, we are embracing this concept of open innovation, which was launched by Professor Henry Chesbrough in UC Berkeley, where we are able to do as much meaningful partnership outside our health system as we do inside our health system. And that's why we enabled the first healthcare cloud innovation center with AWS. Now we have 12 AWS innovation centers, but we are the first one in healthcare. And Niti Aayog in India is a part of that. So creating a global ecosystem with Singapore, with Australia, with Israel, with India, as well as in US, to learn together this new, what we call as a science of digital medicine. So this shows some of our partnership we have built, and we love to work with API, with Gapio, with Apollo, to kind of build that ecosystem, what we call as a highways for digital care. So whatever we are learning, we make it available to you. Whatever you are learning and you are doing, we make it available here. And together we embrace this new world of one-to-many care, where this automated digital care pathway becomes extension of physicians and surgeons, but not limited to one-to-one, but we can do that to millions of patients at once. And together we can create this new science, combining the innovation that's happening with the rigor of evidence-based medicine to create the new science of evidence-based digital medicine. All these chatbots, telehealth, digital care, digital therapeutics, I see them as disciplines of evidence-based medicine. Very much I see anatomy, physiology, biochemistry as fundamental building blocks of medicine. We need to have this fundamental building blocks of digital medicine. And this is a wonderful opportunity for us to create efficiency that has never been possible before. So I want to end in time on this. Hockey with Gapio here, with API, with Apollo, create a global collaboration ecosystem to support exponentially better care using digital health and virtual health. For such other things, so we are able to take the best of these needle in the haystack approach. And how do we start building common solutions together through co-innovation? And I'm sharing my email and we'd love to hear from you and be part of the discussion. Thanks for having me.
Thank you, Dr. Treja. Really appreciate this wonderful talk, and I'm sure Dr. Kohli will agree with me. We would love to, have you involved in the team and extend any kind of help we can from API to make this go forward. Thank you once again for this great talk. I would now like to bring Dr. Anupam Sibal back on the floor and, go ahead and hand the mic to him. Thank you, Dr. Sibal.
Thank you so much, Anjana. Thank you, Ashish. A brilliant session, wonderful talks already. For me now, it's a privilege to introduce Dr. Sangeeta Reddy, Joint Managing Director, Apollo Hospitals Group. Dr. Sangeeta is going to speak on digital health, the future of healthcare in India. Dr. Sangeeta Reddy, as we all know, is a global healthcare leader, entrepreneur, and humanitarian. She's the Joint Managing Director of the Apollo Hospitals Group, Asia's largest and most trusted healthcare provider. Dr. Sangeeta Reddy was the president of the Federation of Indian Chambers of Commerce and Industry, better known as FICCI, in 2019 and 20. She was only the third woman to be elected as president of FICCI in 92 years. As one of the founding team members of the Apollo Hospitals Group, Dr. Sangeeta is passionately committed to transforming healthcare systems through technological advancements and is accelerating positive transformation in enabling universal access to healthcare. Dr. Reddy has been conferred with an honorary doctorate by the Macquarie University, Australia. She's the Honorary Consul General of Brazil in Hyderabad and is a recipient of numerous prestigious awards for business and leadership. Over to you, Dr. Sangeeta Reddy.
So, namaste, good morning, good afternoon, and good evening. It is indeed a pleasure to be amongst all of you, and thank you for marking this significant day in the development of telehealth and in the progress of Apollo by having this thought-provoking and really strong leadership program. Dr. Ravi, all other seniors who are here, speakers before me, once again, just a warm thank you for coming together to really acknowledge the powerful role that telehealth is playing across the globe and especially in India, where I will be talking about. And I share so many ideas and thoughts with what Dr. Ashish mentioned before. But I just want to really begin by thanking everyone who's made this journey possible. And it was really at the turn of the millennium, and I think Dr. Ganapathy must have spoken about this when we did the Aragonda telemedicine with Bill Clinton. And just 2 weeks before that event, I was in Aragonda and we were trying to imagine how are we going to make this happen when the world is going to be watching us. Because at that time, our telemedicine was 3 telephone lines combined together to create the bandwidth to do the connectivity. And we had wired the CT scan, we had wired the echo machine, but we said if the bandwidth fails, if it's inadequate. And then we quickly went to our space program in India and got a VSAT and said, please give us dedicated bandwidth, knowing fully well that VSAT is not the long-term answer. But as you all know, over the last 22 years, India has transformed. And what happened that one day when we were standing there with bated breath, we had put together the program, we had trained the doctors, we knew the technology, but we also realized that this was the beginning of opening doors to say that we never have to deny anybody care, because doctors who are willing can reach out to any part of the world, to any corner of the world, to give their expertise, to give their capability. And from that time, 22 years ago, the landscape has just changed and evolved. India has among the best teledensities in the world. We have, I think, the eSanjeevani program of the Indian government has become the world's largest telemedicine program. We today talk not just about one-to-one teleconsultation or conversations like we're having today, but these have at the back end care modules, clinical decision support systems, AI-enabled chatbots. We now are using AI-enabled symptom checkers to direct a patient to who is the most appropriate based on their top 5 complaints or presentations. We then tell them this is the most appropriate doctor for you. You schedule the appointment within 15 minutes or a day or 2, depending on the seniority of the doctor or the urgency of the patient. You finish a teleconsult. This is automated. There is voice recognition. Your EMR is capturing this data. This goes and sits in your PHR or your personal health record, which is sitting on your phone. When your doctor says, get this diagnostics done, you can click a button, pay for those tests, and the phlebotomist will come to your home and get these tests done for you. When he prescribes medication, you click another button, your credit card pays for it or your digital payment pays for it, and this medicine will be delivered at home. And behind the convenience and the automation part is the power not just of access, not just of quality and reach, but I think that powerful word that Ashish used earlier, Dr. Atreja, of exponential. The power to reach out to every corner of the world. It's not just India's 1.3 billion people who need more care, who are denied care, but it's many parts of the globe. And that is the power that telehealth and digital is enabling us. So whether we're looking at the access aspect, or can you go to rural India, can even an urban city access a super specialist? Can you look at telementored surgery? What are we doing in terms of that entire? So there's access as one pillar. The second powerful pillar, which also has been spoken about a little, is the entire space of automation. And it's not just the scheduling and the convenience or the coding or the claims, it's automation in terms of the back-end processing so that repetitive jobs are automated in a manner that time is enabled for doctors to really spend with their patients. So whether it's patient instructions, how do you prepare for a gastroscopy is the example that Dr. Atreja gave us, but there are hundreds of these examples. Why do you come fasting? What do you do before surgery? What is the prep? What do you bring? Things which were communications that happened repetitively again and again, maybe by a doctor, maybe by a care nurse, maybe by a scheduling manager or a day surgery center manager, is now beautifully converted into videos. One tick to say, yes, I understood and I'm ready. So the entire process is changing, but in a simple word, we're using the protocols and the patterns that other industries, whether it was the banking industry or the retail industry, how do you order your groceries? All these have changed, and so is healthcare changing. But I want to take this a little deeper than these two. The access and the automation are at level 1. The deeper and the more significant aspect, and that's what I think all of you are most concerned about, is the entire aspect of quality. Because however much you want to do everything, there is such a changing world. And the aspect of quality is coming in AI-enabled decision support systems and in powerful education, as well as point of need information systems. The combination of these 3 pillars is really, I believe, one of the most powerful aspects of the telehealth revolution, which is really changing everything that we do. So I want to share from a country like India, where we have, it is estimated 85 million diabetics, and the implications of untreated or unmanaged diabetes is very well known to all of you. We came into what was called at that time a program called Sugar. In the Sugar Clinic program, when the patient went home, we taught them how his glucometer could message the value to his mobile phone. His mobile phone was connected to his care team. The care team had triggers, it had a chatbot, it had a mentor, there was a dietitian, and we were counseling this patient in terms of modification of dosage, counseling on weight loss, on exercise, and on monitoring himself. And I just want to share that at the end of the day, I'm really proud of the team that put together this program. And of the 75,000 patients who have been on our digital program, so this is not just the consult, this is a digital condition management or digital therapeutics program, where of the 75,000 people, 83% of them had their diabetes or their HbA1c under 6 in a period of 90 to 120 days. So this is an intervention methodology which is here to stay. This is something which is here to stay, not as an adjunct which will be promoted by insurance companies, but a powerful tool that I request doctors to take in your hands so that you can make sure that your patients comply, that there is drug compliance, there is behavior compliance, there's lifestyle modification, because we all know that non-communicable disease is really the largest tsunami or the underlying epidemic, far greater than the COVID epidemic. And it's for us to use whatever we can in terms of tools to modify this. I want to spend a minute on something which I think is as powerful as the EMR, and that is the PHR. Very few people may know that in the government of India's digital policy, the personal health record has also been mandated or described. It will use the same data standards. It will be governed by the same ISO, and incidentally, I'm very grateful to our team. Our telehealth team was the first in the world to really go out there and get the ISO 13131 or 13131 certification. This is the telehealth specific ISO standard, which includes device integration. So today we're pioneering with devices like DOSI, which is an under bedsheet monitoring of the respiratory rate. We're looking at contactless sensors. Of course, wearables are a very powerful part of the entire continuum of care. And it is in this environment of devices, wearables, AI-enabled chatbots, voice-enabled environments or feedback, call centers, medically manned call centers, CRM, or just an ability to maintain the record and build a relationship with the patient and do the follow-up, that I see that healthcare is transforming from the episodic, fantastic time that a patient spent in a doctor's office to a continuum of care, which is far more powerful than ever before. And underlying this capability is coming the move, is that care is shifting. And all of you are seeing this happening. Care has, of course, been shifting for a few years from the hospital to clinics, to surgery centers, to specialty centers. But it's shifting again from the surgery centers into the home or the nursing homes. And yet again, to a ubiquitous anytime access to care enabled by the mobile phone, because all your data is available right there. And beyond your data, your access to expertise, to intervention, to ordering, to medication is all coming up in apps. And at the back end of these apps is the powerful knowledge and capability of thousands of doctors who are building these care protocols or these AI-enabled systems. It is in the world of this environment where access, automation, quality, PHRs, continuum of care, devices are all coming together that I want to share one last point, which I think is of equal importance and perfect for a platform like all of you, and that is education. Because it's conferences like these, but beyond that, the didactic one-to-one classroom lecture is gone. The didactic one-to-many classroom lecture is gone. Today, you have the best videotape lectures, and those are now being absorbed. So like the Salman Khan Academy, and then there's case discussions. But moving beyond is a new platform that I hope I can very soon offer to all of you, is a platform called Expert, which is acknowledging that knowledge does not come only in classrooms, that you're learning not just in an intervention or a planned intervention, but whether it's a blog, a newspaper article, a case study, a discussion, a grand round, or a classroom, learning is happening all the time. And it's in that environment of synchronicity or a seamless flow of this learning experience that we are going to see a major shift. And as medicine continues to advance, and what was yesterday's standard of, major innovation is going to become tomorrow's routine standard of care. It's in that environment that the pace on learning, on training, on collaboration, and on digital adoption is becoming more and more powerful. So I just want to thank all of you for this opportunity to communicate. I want to share with you our continuous commitment to really be part of an evolving ecosystem which is dedicated to just one thing, and that is to the enablement of access to the highest quality of care to everyone in the world. And this is high quality care at the best possible price, because what we're doing today in healthcare in many environments is not sustainable. There is a great need to enable access, to make healthcare available, but to also make it affordable and at the same time keep enhancing the quality. So as we continue to push the frontiers of science for better and better care, as people live longer and longevity puts more pressure on all of you clinicians to find ways to create care most cost effectively, we must find ways to use digital, to use the larger ecosystem of care providers beyond the doctors to support all of you in enabling, in quality assurance, and in the most powerful aspect of all, which is in incorporating the patient or the healthy individual into the overall pathway of care and making them co-responsible. And my final thing, I think, which COVID has taught us more than anything else in the world, that health, which was the responsibility at one time of the general practitioner or the individual doctor. Then came large hospitals, then came larger health systems. Then governments took responsibility for healthcare, like is happening in India now with Ayushman Bharat. Something we started post the Aragonda experience was really the ₹1 a day health scheme. But now health is really a platform subject. But governments also are not responsible for healthcare. Corporates are not responsible for healthcare. And neither is just the individual. Today, the acknowledgement is very clear that health is the responsibility of the entire society. It is corporates, it is scientific institutions, it is food companies, it is the tobacco and the alcohol companies, but it's also the regulatory environment and the enlightened individual, spiritual leaders, mothers, fathers, homes, everybody comes together to create a better healthcare world. So I reiterate our commitment to helping and participating and sharing any of the thoughts and processes towards evolving this better world. Thank you all so much.
Thank you so much, Ms. Sangeeta. As always, very inspirational. And For many of us who've worked with you, I, for example, have worked with you for 25 years. I know the passion that you bring to any and every project that you lead. Thank you so much for that. Going to now request Anjana and Dr. Ganapathy to lead the Q&A session, please. Over to you.
Thank you, Dr. Anupam. If there are any questions from the virtual audience? I think Dr. Tandon had asked one question about the role of digital health in COVID-19, and there has been one or two answers. If I may add my 2 cents worth, I think the fantastic response of the Indian government of India to containment of COVID as compared to most other countries in the world is due to the use of digital health in every way, right from administration to education, telephonic messages. I mean, there are at least 1,000 different ways in which they did it: vaccination, compliance, adherence. And it is not at all an easy job to provide vaccination, 2 doses, 3 doses. I think more than 2 billion doses of vaccination have been given within 9 to 10 months. And Dr. Tandon, this could never, ever have been done without the use of digital, some way or the other, whether you call it digital health or use of, computerization, information and communication technology. So the answer to your question is everything, not just diagnosis and treatment, prevention, compliance, all that is what I think has brought the COVID virus reasonably under control.
If I might just add, looking at data points, Arogya Setu, the government of India's platform, became the most downloaded app in the world in the first 2 weeks when the pandemic was declared. And if we look at the work that we've done at Apollo at AI, our AI tracker got downloaded 16 million times. So, that's the kind of coverage that digital has been able to sort of achieve, which of course has really made such a huge difference in our entire approach to the pandemic.
I think we do have another question right here from Dr. Khanna. What is the legal implication and legal clarity of digital medicine? And anyone who would like to address it, maybe including Dr. Reddy. Yes.
Yeah, so happy to take a first cut at it. Let me just begin by saying that at the height of the pandemic, I was really happy that something that we had been requesting for 7 years, which was the telemedicine guidelines and legislation, got done in 2 weeks. And so we currently now have a framework for telemedicine and for the use. It is legal and effective. On AI, basically, I think that there is, in the US, you have the FDA approval for AI protocols. In India, we are currently using ISO, and that's why I spoke about the ISO 131/3131 as the current standard for telehealth, which includes AI. There are more protocols coming out towards this, but I think it's important for all of us to be cognizant of the importance of validation of science behind, because AI is becoming one of the most misused words. So thank you for that great question, Dr. Khanna.
Anyone else who would, yeah, absolutely, Dr. Ganapathy.
If I can just add a little bit, I think, as one who has been very familiar with telemedicine, as of a few weeks ago, there has not been a single problem in any consumer protection forum or any court of law on a teleconsultation. And we would have done at least 40 to 50 million teleconsultations in the whole country together. The Supreme Court has on many, many occasions made it very clear that the judgment is entirely contextual. It depends on the context. At the worst, a doctor can be reprimanded for an irregularity or a lapse of judgment. That is the worst scenario. I don't think we should be too much concerned. I personally am not at all concerned that there is no law which permits me specifically to do it. At the end of the day, I have only one purpose for my existence, that is to do what is best for the patient. So long as there is no ulterior motive, so long as there is no mala fide intent, res ipsa lociter, that's a Latin phrase, the thing speaks for itself. So I really don't think we should bother too much about it. documentation is the most critical thing. So long as I document everything and explain why I took a particular decision, whether to do a consultation on audio or video, or why I decided to call off for teleconsultation because I was not happy. It's a clinical judgment which is contextual, appearing to that person, at that patient, at that time, under those circumstances. So I really don't think I'm bothered too much. With all respects to the people in the United States, I think people in America are paranoid about medico-legal. Luckily, we are following the West, but we have still not reached that stage. And some amount of trust is still holds good in India.
Well, I think Dr. Ravi Kohli wanted to say, oh, Dr. Reddy, do you want to?
Sorry, just one more line. I'm equally passionate as Dr. Ganapathy, but I will say that there are a few steps that we need to take. For one, that we don't have a standardized drug database. The room for errors are still high, and therefore we need to keep working. We had, worked on the government standards. So India now has a national license for SNOMED code, but the training aspect of adoption of coding is still a journey. So we have some things to be done. Yet at the same time, I am extremely positive about the outlook for telehealth and the safety for the physicians. So I would invite clinicians of API and GAPIO to please join us wherever we can. We are currently covering about 60,000 villages in India in the government system of the CSCs. We are doing many, many telehealth centers. So anyone who wants to donate their time, I want to say this also, if there is no commercial transaction, there is no implication for legal recourse. Consumer protection does not cover a non-commercial transaction. So anyone who's interested, please do feel free to write to us to start, even if you want to donate half an hour a week to start on this telemedicine journey. We'll be very happy to aggregate clinicians and put them forward, or the eSanjeevani platform. There are other government platforms as well, but it's a very powerful medium, and it's for all of us to explore the power of this exponential reach.
Thank you, Dr. Reddy. I think Dr. Ravi Kohli wanted to say a few words.
Yeah, thank you, Anjana, for giving me that opportunity. Again, I just want to address a couple of things Dr. Atreja mentioned. He mentioned about the problem of the plenty. There is a problem with capitalism. Wherever you go, there are 10 different constipation relief medications or shampoos, and same thing is happening with the digital care. There are so many platforms. How do we standardize them? How do we get the best out of them? The second thing is trust. Again, trust is the most important transactional part of the equation. There is a digital divide, right? We have a digital divide that has been actually been exploited to further misinform and disinform large swaths of population. So we need to bridge the digital divide. The access itself also is a problem to many people, especially the older people who will be our consumers. How they can use it, how they can participate in it, is another thing that we need to build. So building trust is so important because of the misinformation that goes on. And you also talked about digital highways. And as you know, the highways in the US has actually divided communities into ghettos and downtown, suburban, economic and wealthy parts. So we need to make sure this technology is not going to divide us further and tear us apart further, and bring us together and build the standards of care. And again, Dr. Sangeeta Reddy said, it's the corporate social responsibility. As long as there's no profit, less profit motive, more service motive, I think we can bridge these gaps. But I think we all have to play a role, organizations, academics and policymakers, patients, education, everything has to come into play. I think we're at the right cusp of the movement to take this forward, to really make it an impactful revolution in healthcare.
Thank you, Dr. Kohli. And, it has been such an interesting discussion. We can go on and on. Maybe we should have another conference, tagging into this later on. But because of constraint of time, I think we have no further questions at this point. So I would like to invite Dr. Ravi Kohli, the President-elect of API to give the closing remarks. And thank you everyone for coming and giving these wonderful talks and being a part of this conference. Thank you.
Again, yeah, I pretty much spoke all the things I wanted to say anyway. Really appreciate Dr. Anupam Sibal, Gapio, Dr. Sangeeta Reddy, Dr. Tandon for making this possible and bringing all of us together here. And it has been a great story that we heard from the beginning, the pioneers to the proponents and the advocates and the future. We talked about telehealth India, yesterday, today, tomorrow, the Apollo story, the global perspective from the insurance and telehealth, digital health, not digital examination, but digital healthcare from gastroenterologist Dr. Atreja and Dr. Sangeeta at the corporate point of view. And an excellent question and answer session by Dr. Ganapathy and Dr. Anjana Samadar. I really appreciate all of you being here and participating, and we're looking forward. As we speak, Dr. Anupama Gotimukla, our president, is working on MOU to be signed with Apollo on some of the aspects we talked about here. So hopefully, Dr. Bhavana Chhabra is also a good friend and has been liaisoning with us. So we're looking forward to doing more things together with Capio and other interested corporations and public health partners. Thank you.
Thank you. Thank you. On behalf of Gapio, thank you very much. Really want to acknowledge Dr. Ganapathy's push and idea and making this happen. And I know 24th March is so well ingrained in your cerebrum or deeper recesses of the cerebellum that no matter what happens, 24th March, something lights up in Dr. Ganapathy's very, very agile and fertile mind. Thank you so much for joining, and till next time, have a wonderful weekend.
Thank you.
Thank you. Take care and stay safe. Namaste.
Namaste.
Thank you.
Namaste all.
Bye.
Thank you, everyone. Thank you very much.